Hello students. So we will discuss another neurological emergency, meningitis encephalitis, presenting in ED, emergency department. So bacterial meningitis or viral encephalitis are life-threatening infection and inflammation of central nervous system, right? Now meningitis is an inflammatory process of the membranes that surround the brain and spinal cord. Meningitis is infection or inflammation of meninges that is surrounding the brain and spinal cord, right? And encephalitis is infection of brain parenchyma causing inflammation within CNS and is more often viral in origin, right? It can be caused by variety of viral pathogen, right? Like including HSV is one of the virus infection causing encephalitis is one of the most treatable cause. So it is of most importance to us. Okay. Now it is very difficult to distinguish between meningitis and encephalitis in emergency department. It is difficult to differentiate between both of them because their presentation is mostly the same. It's similar presentation, right? So management is mostly guided towards both empirically. Okay. What do we do whenever I get a patient of most probable of bacterial meningitis or encephalitis in whom we are suspecting a CNS infection? Like any other patient, we go for initial evaluation and primary survey. So ill appearing patient, right? Patient who is not looking good in appearance with suspected CNS infection is showing fever, signs of neck rigidity, right? Altered consciousness, and they are ill appearing, should be very promptly evaluated. I will tell you, we will discuss in the further slides what is the line of evaluation in these patients, and monitored and treated appropriately. Fast management is the crux of saving life of these patients. So they should be promptly evaluated, monitored for any change in their situation, and they should be treated appropriately. If the patient has a rapidly declining consciousness, patient is deteriorating very fast, then the focus should be in primary survey, right? Patient actually can present as a can present differently. Patient may be ill appearing but stable. So them just evaluation and monitoring and management is to be done. But the patient who is rapidly deteriorating, in them we need to do the emergency management first and then evaluated and accordingly appropriately treated, right? So in these patients who are rapidly declining, rapidly deteriorating, we have to prioritize ABC. So patients who are rapidly deteriorating, airway, breathing, circulation should be prioritized. So stabilization of airway, breathing, circulation is done as any critically ill patient, right? If bacterial meningitis is the likely diagnosis, most probable diagnosis is bacterial meningitis, right? Antibiotics should be immediately administered, if possible, after prompt lumbar puncture. So if it is possible, we do a prompt lumbar puncture and then give an antibiotic therapy, because when the gram staining of the CSF would be done, we can direct our antibiotic therapy accordingly. So before empiric antibiotic, a lumbar puncture and a blood culture, if possible, can be done. But definitely, if this will delay the therapy, then we don't wait, right? We don't wait. We administer antibiotic as fast as possible. Okay. In emergency department, typically we don't know the pathogen patient has come from where. So a broad specific empiric antimicrobial coverage is recommended. A broad spectrum antibiotic is recommended. Okay. If it is the emergency medicine providers are suspecting viral encephalitis, I will tell you there are few things which can help us in differentiating bacterial meningitis and viral encephalitis. If the likely diagnosis is going towards viral encephalitis, then that is patient has suspected CNS infection, altered mental status, and focal neurological deficit. Then antiviral therapy, acyclovir therapy in HSV encephalitis should be immediately started. It is very important to remember that therapy in the acute stage is most advantageous for the patient, and the survival of the patient is dependent upon that. So if a viral encephalitis is suspected, then definitely IV acyclovir should be started. Now let us discuss, this is the initial management. Let us discuss few things about the clinical features of these both conditions. What is the clinical feature of patients with meningitis? The classical triad of meningitis. Patient has fever, patient has neck stiffness and altered mental status. Though must tell you that various studies have shown that in not all the patients this classically come together. So definitely diagnosis is difficult to make. Number of times the early symptoms of meningitis is non-specific, right? Patient will have headache, patient will have nausea and vomiting, patient will have neck pain. So very non-specific kind of symptoms, which makes very challenging to diagnose this bacterial infection or viral encephalitis, bacterial infection of meninges or viral encephalitis. Now patient also may come with a confusion, altered mental status, seizure as the disease progress. So initially they have non-specific symptoms. Later on when they are coming, they have more symptoms which needs a more rapid management, like confusion, altered mental status, seizure, etc. as the disease is progressing, right? So a thorough history of the current event is very important in these patients. If we take the history very properly, how the condition progressed, we would get a very good idea that what the patient has come up to, right? And one more important thing, that extremes of age, that is very old patient and young patient, children, and immunocompromised patient also present very differently, very vague symptoms, very subtle presentation, very difficult to diagnose. Number of times meningitis patient does not even have fever. So again, the diagnosis becomes very difficult. Chief complaint in infant can number of times only be irritability, lethargy, poor feeding, rash, or signs of raised ICP like bulging fontanelle. So non-specific patient, the infant may not have a fever, will just be irritable, would just have a tendency towards poor feeding, maybe lethargic, may have a rash, or may have a bulging fontanelle. Sometimes this also not is there. Seizure may be the presenting symptoms, right? So pediatric patient, number of times seizure is the presenting symptoms. In older age group, the most common presenting symptoms is altered mental status, right? Altered mental status. This is the chief complaint. Okay. The clinical presentation of encephalitis is similar to meningitis. Only in encephalitis, there may be along with presence of altered mental status, there may be neurological symptoms, right? Meningitis, focal neurological symptoms less, and if there are focal neurological symptoms, it is more pointing towards encephalitis, right? What are the physical findings in these patients? Common physical findings include febrile patient, although patient will, most of the time, the patient will have fever, although studies have shown that meningitis encephalitis without fever, right? So it cannot be that if there is no fever, it is diagnostic that patient does not have brain infection. It can be without fever also. Remember, in extremes of age and in immunocompromised patient, lack of fever is very common, right? Now classically described meningeal findings like knuckle rigidity, neck stiffness, right? Severe neck stiffness, due to meningeal irritation. So patient we may during physical examination see neck stiffness, right? Again, this may not be present in every patient. There are few examination which is done like Kernig sign, Brudzinski signs, which is seen for diagnosing the meningeal irritation. Kernig sign, what is done in Kernig sign? Hip is flexed and knee is extended. Flexion of neck, flexion of hip and extension of knee. This starts pain in back and legs, right? Both Kernig signs or Brudzinski sign, both are non-specific. In Brudzinski sign, there is a passive flexion of neck. Passive, when the neck is passively flexed, there is a flexion of hip. Hip is flexed, right? These are also non-specific signs. It is not that if they are absent, patient may not have bacterial meningitis or encephalitis. They are non-specific. They may be present, they may not be present. Neck stiffness is also only present in 30% of the patient with bacterial meningitis or encephalitis. Now, along with these physical findings, when an examination of the patient is being done, there may be presence of petechia, rash, etc., which is very commonly associated with meningococcal meningitis, right? However, it may also be present with other meningitis. Altered mental status, focal neurological findings, right, should point towards encephalitis more than meningitis. Okay, so whenever I get these patients, I have a patient with fever, altered mental status, focal neurological signs, we can go for lumbar puncture. Immediately we can go for lumbar puncture and then we can give antibiotic to our patient, in broad spectrum antibiotic. Now, lumbar puncture is the preferred diagnostic procedure, and it is good, it is preferable if prior to lumbar puncture we do a CT scan to rule out any intracranial pathology. Since presentation of meningitis, encephalitis is very similar to number of intracranial pathology like ICH, subarachnoid hemorrhage or mass, cerebral mass, etc. So we have to rule out all these conditions. So a CT scan is done to rule out these conditions, right? So CT scan should be considered if patient has, always should be considered if patient has altered mental status, a new onset seizure, patient is immunocompromised, focal neurological deficit or papilledema is present in the patient prior to lumbar puncture. Okay, lumbar puncture, how is the lumbar puncture done? In case of suspected bacterial meningitis or encephalitis, 4 tubes of CSF is each containing 1 ml of fluid is typically obtained, right? What are the initial CSF laboratory studies which are done? First tube is used for cell count and differential cell count. Second tube for protein and glucose. Third for gram stain, and fourth for bacterial culture, right? Now, number of conditions in which it may be required to do additional CSF studies, right? The number of patients, features in them prompt us towards some particular pathogen. So in CSF, we can study those pathogens also. Additional CSF studies is required, may be required in immunocompromised patient, right? Or if a CNS infection is suggested based on initial laboratory testings, right? So when we do a lab test, it points towards certain pathogen. So we can go for that pathogen also, like patient has a history of tuberculosis, etc. So we can go for those specific tests also in CSF, right? So other CSF studies which we can do is HSV or enterovirus PCR, right? Bacterial antigen testing or specialized fungal testing, right? If patient is immunocompromised and most likely pathogen we are suspecting is fungus. So we can also go for specialized fungal testing in CSF, bacterial antigen testing in CSF, right? So these can be done, okay? Now, patient present with elevated or possible CNS infection, most of them, right? We should have a complete CBC profile done, complete blood count done, glucose, electrolyte, urea nitrogen, creatinine, basic laboratory investigation is must, right? Now, one major problem is that most of the laboratory investigation are non-specific for meningitis or encephalitis, right? So they are just for let's say patient well-being, a baseline investigation which we are seeing. So none of them are pointing towards a particular pathogen, a particular bacteria. So normally after doing all these tests, we start a broad empiric antibiotic, right? Broad empiric antibiotic is started. Okay. Now classically, what is the CSF finding? CSF finding, very fast we'll just see on the basis of CSF how do we differentiate between bacterial, viral and fungal meningitis. Bacterial, viral and fungal meningitis. Now remember, in viral meningitis, the CSF pressure is normal, elevated in both bacterial and fungal meningitis, right? In case of white blood cells, total TLC in CSF, it is highly elevated in bacterial meningitis and less in viral and fungal meningitis. Neutrophils, differential count, more than 80% of the WBC present in the CSF would be neutrophils in bacterial meningitis, right? Viral and fungal meningitis, it would not be neutrophils. Then glucose is reduced. Glucose is reduced in bacterial meningitis and it is normal in viral meningitis and may be reduced in fungal meningitis as well. Protein is elevated in bacterial meningitis, normal in viral meningitis and elevated in fungal meningitis also. And gram staining in bacterial meningitis will be bacterial. It will be positive for the bacterial. So we will get bacteria in gram staining for bacterial meningitis. So mostly total TLC count, differential count and glucose and protein level, right? Glucose is reduced in bacterial meningitis and protein is elevated in bacterial meningitis. So a very fast CSF report is obtained, which can help us in focusing our treatment, right? Now for patient with suspected bacterial meningitis, empiric intravenous antibiotic therapy has to be started, right? And patient should be admitted into the hospital. CNS infection, suspected meningitis, patient needs to be admitted because antibiotic would be given in IV, right? So patient with severe disease may require ICU level care depending upon the clinical circumstances of the patient. So they need to be admitted in the hospital because most of them would be given IV drugs. Now along with broad spectrum antibiotic, I would not go into the details of the antibiotic. According to the age, a broad spectrum antibiotic is given and later on according to the culture we can narrow the spectrum of the antibiotic accordingly. Okay, so I would not go into that. Just I'll say a broad spectrum antibiotic is started. And very important, treatment of the most cases of encephalitis is supportive care. Viral encephalitis, mostly the management is supportive care, right? Only HSV encephalitis has a specific treatment, that is acyclovir, intravenous acyclovir. So it should be started as fast as possible. Intravenous acyclovir should be started as fast as possible in case of suspected encephalitis. Okay. Now there is a recommendation that patients we are starting with antibiotics, they should also receive adjunctive corticosteroid treatment. It has shown some clear-cut benefit in these patients. So it should be started before or along with the first dose of antibiotic. Yeah, we have to start corticosteroid along with the first dose of antibiotic or before starting the antibiotic. This has decreased, studies have shown that this has decreased the mortality and neurological sequelae for the subset of the patient with bacterial meningitis, right? So some patients are being benefited in the studies with adjunctive steroid, so it is preferable to give steroids in these patients, right? So consider intravenous dexamethasone every 6 hours for 4 days in adults and children 3 months and older, right? So children 3 months and older and adults for 4 days dexamethasone 6 hourly is given, right? In patient who needs CT scan or CT scan of brain prior to LP, blood culture should also be drawn, right? Blood culture should also be drawn before giving empiric antibiotic therapy. Okay. Now, so I have started antibiotic. I have given my patient steroid. Now, so I have started a initial management of my patient. I have done all the investigations. Now, how I will dispose this patient? Remember, disposition. Most of these patients are admitted into the hospital for further evaluation and empiric IV. Encephalitis patient also require inpatient treatment, right? Rarely some well-appearing patients of viral meningitis, right, may be suitable for outpatient treatment with a careful return and follow-up when required. But most of these patients should be admitted because drugs are given intravenously and deterioration can happen in these patients, so they should be always admitted, right? Should be admitted. If diagnosis is unclear after emergency evaluation and still bacterial meningitis remains a likely possibility, then also patient should be admitted and started on empiric antibiotic treatment, right? Remember that if lumbar puncture results are negative for CSF infection, then other additional inpatient or outpatient diagnostic testing may be done, right, depending upon the appropriate clinical condition. If lumbar puncture is not showing any infection but patient is pointing towards bacterial meningitis, empiric antibiotic has to be started and other investigation is done to rule out the other causes which can be present in these, which can be a differential diagnosis of bacterial meningitis and encephalitis. So disposition is dependent upon the patient, right? If the disease is established, then also patient is admitted. If the disease is not established, then also patient is admitted for further management. Okay, thank you.